Scott Brown's Otology, Chapter 85, Ossiculoplasty, Surgical Options to Correct Specific Defects. Surgical options to correct specific defects. Due to the wide variation in surgical practice and increasingly large range of processes available, it is not possible to give an exhaustive account of all surgical options for each reconstruction. What follows are illustrative examples of proven surgical strategies. Box 85.1 Terminology. PORP, partial ossicular replacement prosthesis, generally used to mean a prosthesis that is designed for situations with an intact stapes superstructure. TORP, total ossicular replacement prosthesis, for use in situations where there is no stapes superstructure and the prosthesis restores a connection with the stapes foot plate. Ossicular reconstructions are referred to as columella when the sound transmission is restored with an ossicle to tympanic membrane connection, and assemblies where there is an ossicle to ossicle connection. Introduces ossicular reconstruction or replacement terminology. Eroded long process of incus. This is the most common ossicular chain defect encountered in patients with chronic middle ear disease of all etiologies. Early attempts to restore hearing in case of ISJ separation included stapediopexy, where the tympanic membrane is brought into direct contact with the stapes head. This approach has the obvious disadvantage of losing the amplification and dampening the functions of the ossicular chain. Preservation of the natural anatomy is preferable and can be achieved by following methods. Figure 85.1 PORP on intact stapes. A. The partial ossicular replacement processes is in situ on intact stapes superstructure. The cartilage and perichondrial graft lies between the prosthesis and the tympanic membrane. B. Partial clip prosthesis sitting on stapes inferior to eroded incus long process which remains in place. Bridging with autologous tissue. Where there is a small distance of separation between the stapes head and incus long process remnant, interposition bridging may be attempted. Materials that are most frequently used for this purpose includes autologous cortical bone harvested from the mastoid or external auditory canal or cartilage. Reconstruction of longer defects may be unstable and can lead to unpredictable results. Bridging materials may be partially resorbed, displaced, or form bony ankylosis with the canal wall. Prosthesis. The first described ISJ replacement prosthesis was reported in 1993 and considered of a basic cuboidal hydroxylapatite design with a circular aperture for the stapes head and a groove to accommodate the long process remnant. A variety of other processes have been developed over time, differing in both material and design. The interface with the stapes head may be a simple cup, although more recent adoption of titanium and improved manufacturing techniques allow more complex designs such as self-securing clips. The processes may accommodate the incus long process remnant with a groove, wire coil, or circumferential crimping attachments. Bone cement plate. The use of bone cement to reconstruct the long process of incus is more recent development and has been shown to give good hearing results, at least in the short term. Studies show 80% of patients achieve AR bone gap closure to within 20 decibel at 1 year. Care must be taken when applying bone cement to avoid spillage onto the stapes foot plate or unintended fixation to the posterior canal wall. An alternative to cement is the use of bone paste, which can be collected by drilling healthy mastoid cortex. This option works best when were, there is still a partial connection between the long process of incus and the stapes head. Some surgeons mix the bone dust with blood and or fibrin glue to aid adhesion. Eroded incus with malleus stapes present, Ossiculoplasty type A. Figure 85.2 Incudiostapedial joint reconstruction. A. Erosion of the long process of incus with the tenuous fibrous attachment left and can be reconstructed with cement or bone plate in the right side. B is the eroded incus. B is the eroded incus and C is the incus reconstructed with bone cement. Eroded incus with malleus and stapes present, Ossiculoplasty type A. In cases where the incus is partially or completely eroded and anatomically reconstruction of the ossicular chain is not possible, there are several alternative options for restoring hearing when the malleus handle and stapes superstructure remain intact. Autologous ossicle interposition. Repositioning of the incus as a method for restoring the function of the ossicular chain was first described in 1957 by Hall and Ritzner, since which time it has been shown to be a stable option for reconstruction. When the body and short process of incus are intact, it may be used for reconstruction provided the surgeon is confident it harbors no residual disease. The ossicle forceps and micro drill are used to sculpt the ossicle into the designed shape with a variety of configurations possible. The classical method involves placing the body of the incus on the stapes head with the short process directed towards the handle of malleus and medial to it. Modifications of the technique include creating a groove in the short process so that it rests against the malleus handle or alternatively lateral to the malleus handle. The malleus handle may be used where the incus is not available, although usually it is brought into direct contact with the tympanic membrane, in contrast to the incus assembly which aims to rest against the malleus handle. Cartilage and sculpted cortical bone can be used, although these are more prone to resorption or ankylosis. The use of homograft ossicles or cortical bone has also been described and continues to be used in some countries, with up to 90% of patients achieving less than 20 decibel airborne gap in one series of cases receiving sculpted homograft incus interposition. Partial ossicular replacement processes. Selecting an appropriate ossicular replacement processes requires careful consideration of the anatomical configuration of middle ear and ossicles. The two main options for processes placement are stapes to malleus or stapes to tympanic membrane. Stapes to malleus. Advantages to this configuration are preservation of catenary lever mechanism of the tympanic membrane. Placing the processes medial to the handle of malleus may also reduce the rate of extrusion as compared to the processes in direct contact with the tympanic membrane. The significant drawback in that is in most situations the malleus stapes offset means the vector of force is never perfectly in line to the stapes, thereby resulting in inefficient energy transfer. When the malleus stapes offset is of sufficient magnitude for the interposition processes to have an angle greater than 45 degrees relative to the vertical axis of stapes movement, significant tilting movements occur at the footplate with resultant marked loss of sound transmission. This can be improved by malleus relocation, which involves separating the malleus handle from the tympanic membrane, division of the tensor tympani at its insertion, and stretching or avulsion the anterior suspensory ligament by pulling posteriorly on the neck of the malleus. The superior ligament is left in place to support the malleus. The malleus handle is placed more posteriorly towards a position overlying the stapes head. Figure 85.3, malleus head reconstruction with intact stapes. The malleus head can be used in a stapes to drum configuration to reconstruct Austin-Cartouche type A or type C defects. The left hand image indicates the reshaping required prior to use. Figure 85.4, if the malleus is very anterior on medial, angle alpha increases. As angle alpha gets larger, the desirable force through the foot plate F2 decreases and undesirable tilting force F3 increases. Stapes to tympanic membrane. This approach can be used in cases where the malleus handle orientation is unfavorable due to anterior angulation or medial displacement. The disadvantage of this method is that the catenary lever mechanism is lost and the prosthesis may be unstable as it does not have any fixed lateral attachment other than the relative compliant tympanic membrane. Some prostheses require interposition of a thin cartilage strip between the tympanic membrane and the head of the prosthesis to reduce the risk of extrusion, although not all surgeons feel this is unnecessary. Most prosthesis designs are in shape of a drawing pin with a stud which attaches to the stapes head and a perpendicular flat disc which may be centered on the stud or eccentrically placed. Some newer designs have an open head which allows the surgeon to visualize the stapes during insertion, thereby facilitating this maneuver. Interestingly, some surgeons advocate using torque in the presence of an intact stapes. The prosthesis shaft is placed between the stapes superstructure and the facial nerve directly onto the stapes foot plate. This aims to improve prosthesis stability and energy transfer.